Okay, we're rolling. Dr. Harcourt, welcome to the virtual couch.
Thanks so much for having me today. I appreciate it, Tony.
Yeah, no, I sometimes feel like I am quite the imposter when I talk about on my podcast, the brain. But here I am now talking to someone who literally researches, studies, and works with the brain on a daily basis. Correct?
Yeah.
Hey, before we even get into some of the questions, I noticed in your background, your undergrad was in psychology.
It was. Yeah, that's why I'm always happy to chat with people that are familiar with the same type of field.
Yeah. So tell me about that. What was that experience like? Did you ever kind of think, okay, forget the medical field. I want to sit on a couch, tell people, ask them how they feel,
I did actually. And it, honestly, what it ended up being for me is I shadowed a bunch of different professions, and for me, I like being up, moving around, working with my hands. And so that's kind of what led me to a different field. But I was always fascinated from the beginning with just human psychology and how it works. And it really has actually served us in what we do now, because there's such a big psychological and brain component to things like migraine and post-concussion and other neurological disorders. So, I was first introduced to mindfulness therapy, for example, from my psychology professor back at the University of Pittsburgh, which I'm appreciative of. I got introduced to, John Sarno and all his work with mind body medicine. So it was a really good background to have for the types of things we treat now.
Gotcha. And then, so your background, and I liked how, when I was reading about it, you focus a lot now on, is it migraines, post-concussion syndrome? But it didn't start out that way, right?
No, originally I had just written a paper on a rare form of MS that we had been working with and trying to treat using nutrition and functional neurology modalities. And so I was like, I'm going to work on MS and TBI, because traumatic brain injury was a big thing in our field. And when I got to where we're at now in Santa Barbara, there were some really great resources for TBI, and there were some really good resources for MS. And where I actually found that there was a lot of kind of gaps in treatment was in these functional neurological disorders, things that had obvious symptoms, but not an obvious pathological cause. And so things like migraines and post-concussion that hasn't resolved, or dizziness, all ended up being the same story. Well, I've gone to 15 places. Yeah. Somebody ended up telling me it was in my head, and I still can't get to work, right? And that's kind of what led us down this path.
Well, I may be going backwards too, but I was telling a couple of my clients today that I was going to have you on, and I was talking about migraines, and one of the people immediately said, "Oh no, I've got that all figured out. It's this, I do a pressure point or whatever." But you've got, I like your, you call it the bucket theory? Yeah. And maybe talk about that, because this person was like, well, no, I just tell everybody this is how you do it. But for some reason it doesn't work for them. What's wrong with them?
Yeah. Well, that's kind of the funny thing is, if you talk to somebody with migraines that's gotten better, or you talk to doctors that have helped people with migraines, they'll all tell you they have it figured out until you get a, chronic migraine patient or somebody that's been suffering for a while. You realize it's not the whole deal. And so what happens with migraine is it's ultimately a genetic dysfunction, right? So there's certain genes that actually allow certain parts of your brain to be fatigable, right? Okay. Technically we call it hyperexcitability, but essentially it's the parts of the brain that are supposed to do their job don't. So most of the migraine patients suffer with areas that inhibit head and face pain. And so when they become hyperexcitable, they get head and face pain. That's the cause. But there's all these factors that make you more likely to have migraine, which is why a diet might help one person, or acupuncture helps the next, or medication might help another. But if you understand that it's ultimately this part of the brain, and it can be multiple different parts, well, now you can understand where chiropractic was great for this person, but for the next person it didn't do anything. And so the way I look at it is you imagine the part of the brain that leads to migraine as like a bucket. And when that bucket fills up with musculoskeletal, hormonal, nutritional, emotional factors, and it overflows, then you get a migraine. Okay. All right. Whereas if you have a big bucket, if you will, or a stable part of that brain, now you can deal with all these stressors. You get one every couple years. Whereas if you've had trauma or you've had migraines for a long time, that becomes more perpetual, where the bucket shrinks. So now you try the acupuncture, the chiropractic, or the nutrition, or the pressure points, or whatever, and it looks like they're not helpful. Well, they may have helped to reduce your bucket filling up, but there's too many other stinking things filling it up. And so now it looks like it's not helpful. So you have to basically both look at stabilizing and making the bucket bigger, and also reducing the things that fill it up, all at the same time, if you want to help those patients that are having 15, 20, or 30 migraines a month.
Okay, so some of the self-care or the things that are smart to do regardless can, address a lot of the issues that fill the bucket, but there's still going to be times where the bucket's small or the bucket's large or there's a whole bunch of stuff coming in. I like that. So even if somebody found that all right, she presses her hand and it goes away, then the next time that doesn't work, in my world, whatever tells the brain the what's wrong with me story is kind of really frustrating.
Yeah, absolutely.
Okay, how do you make the bucket bigger? I mean, this is, I like that.
So that's the fun thing, and that's actually where we talk about in the book that I'm working on.
Yeah, talk about that. Okay.
And then I'm also teaching a postdoctoral program in migraine. We just finished up the first round of it last weekend in Florida, and we're actually going to be bringing it to the West Coast, which is exciting. And the cool thing about the program is it's not directed towards any one doctor.
Okay.
Our first module is 25 hours on pathophysiology of migraine. So we want you to make sure you understand it. And so as far as making the bucket bigger, the important part to understand about migraine and neurological conditions in general is typically you think, okay, either the arm's broken or it's not. A person's healthy or they're not. A person has depression or they don't. But the reality is there's gradients of all those things. And so when you look at migraine, we think about the neuron. And so the neuron is not just healthy or dead, right? Okay. The neuron has what's called this resting membrane potential, which means it's negative inside, and it takes enough stimulation to bring that threshold or bring that negativity to threshold, and then you have an action potential which causes a firing of a neuron. Okay. Now in migraine, what happens is that threshold gets closer and closer to firing off. So now you're more and more susceptible to failure, fatigue, and having this migraine. So the way that you change that is through activation. And because what happens when you get a stimulation to a neuron, it creates this cascade that stimulates DNA, which creates more proteins, which makes you have a lower resting membrane potential or less likely to have a migraine. And so if you overdo it though, and so say you do too much stimulation, now a thing that's good for you was too much and now you have a migraine. So this is why a lot of times you'll see people, try exercise or try, massage, and they say, well, it gave me a migraine. Well, that might have not been a bad therapy. It just might have been too much for you at that point. And so when we look at making the bucket bigger, my goal is to figure out what part of the brain or brainstem is not as healthy as it should be. Okay. And then provide therapies or stimulation in order to make those areas stronger, but not too much that it leads to a migraine. So that's why.
Yeah. Oh, and what are my mind immediately thinks of, does this need to be some sort of electroshock therapy? Or, what are the things, is it? Okay. What are other things? Yeah. So
again, depending on the part of the brainstem. So for example, we know that there's areas in the midbrain called the periaqueductal gray that deals with descending pain inhibitory pathways. Sometimes that's aberrant. Well, what is around that area that you could stimulate in order to stabilize those parts of the brain? Well, we know that the brainstem is it's electrical, right? That's how it conducts impulses. And so even basically any type of stimulation that you make around that area is going to lead to some activation to, say, the periaqueductal gray. And so the areas that are closest to that are things like your convergence centers. So as you're following targets in towards your face, as you follow things up and down, proximal muscle activity, all these types of things are midbrain consequences. And so in some patients, we find that those are aberrant, or you can drive those pathways in order to stabilize that part of the brain. And the more and more activity you can do this, the more and more stable that they get. So it can be an eye exercise, it can be a vestibular rehab, it can be peripheral nerve stimulation, so like electrical shock can do it. Okay. We've done vagal nerve stimulation, we do laser therapy, you can do manual therapies, you can do all sorts of stuff. But if it's not targeted at the area that is dysfunctional, it's not going to make a big difference, right? So yeah, I've even seen, people that didn't do well with massage, you just target it to one side versus the other, now they do better with massage, right? So it can be something that simple.
So are there, this might sound too generic, but are there then things that you recommend people do just at the base level, or people that are listening, if they have a migraine, that all right, let's go ahead and rule this part out?
Sure. So there's a lot of great stuff. So obviously, starting with nutrition is a big one. I have a whole diet that I go through. It takes like 30 minutes to make sure that we're dialing it in properly for each patient. But there's some generalities, right? I'm not breaking new ground telling you to, avoid gluten and dairy and caffeine and alcohol, right? People get that. Yeah. But a lot of times they don't get how important that is because they didn't see a big change, right? So my recommendation is don't just try to cut out gluten or dairy or one of those things by themselves. Try to do it all at the same time. Because sometimes if you're sensitive to two things and you only cut out one, now it's going to look like that one that we were still sensitive to didn't help you at all. So I recommend trying to cut out multiple things at once and then see if it makes a change. The other thing is trying to increase your physical activity without causing the migraine. Because a lot of people will avoid, say, rotational activities, or they'll avoid exertional activities because it's led to a migraine. Well, that's not necessarily bad, but if you think you should be able to run for 30 minutes, but it gives you a migraine, well, try 15 minutes or 10 minutes or 5 minutes. Find how much activity you can do without, and then start pushing that more and more each day, because that threshold is what's going to allow you to get healthier and healthier.
Yeah, you talked about vagal nerve stimulation. I mean, is that just good old deep breathing? I mean, is that, or is it more than that?
Yeah, so there's a ton of different ways to do vagal stimulation. The one that's been more researched, there's a device now that you can actually stimulate the vagal portion or the cervical portion of the vagal nerve. And it's just a two-pronged device. You put it on the right side then the left side, so you can directly stimulate the vagal nerve.
Wow.
You can do it with actually through the ear. There's certain places on the ear that you can put electrical stim and do it that way. Deep breathing is great. You can do visceral massage. You can do gargling. So there's all these different things that can be helpful. But again, depends if that's the problem and on which side, because sometimes you'll see autonomic dysfunction more on the right side versus the left side. So if you're going to do vagal nerve stim, you're going to want to do it more on one side versus the other.
Okay. No, that makes sense. Can I ask you too, is there a kind of a default type of migraine, or are there a million? I mean, I hear people always talk about, is there a ophthalmic migraine, or, they see spots, or their vision is gone, or, what do you typically see?
Oh, this is a very long topic, but suffice it to say, there, in my opinion, based on the understanding of migraine, in the next couple of years, we're going to have to come up with a different diagnosis of migraine, true migraine, and migraine-like headache disorders. All right, because what happens is I get a lot of patients that have severe cervicogenic headache or post-traumatic headache or something else that meets the criteria of migraine, even though it's not migraine. Right? Because the gold standard is the ICHD-3 criteria. And if you look that up, but it's not like you have to have this and this. It's like, well, if you have these two things or these two things and this thing. And so now you can have true migraine that's classified properly, or you can have a really bad tension headache, or that's, light sensitive, or a post-traumatic headache that's actually a concussion that now they say, you magically develop migraine. That's not how migraine works. It's genetic. So you don't just get it from getting in a car accident.
Okay. So that's where the distinction would be. If there aren't those genetic components, it's going to end up being some sort of what was the second thing you talked about? Headache.
Cervicogenic, or most commonly we see as post-traumatic. But if you understand how actually migraine works, which is this hyperexcitability of certain neurons, now like an ophthalmic or an ocular migraine makes sense, because now you get that same dysfunction, but more in the occipital lobe. If you have it in the lower part of the brainstem, in the vestibular nuclei, now you have vestibular migraine. If you have it on the entire one side of the brainstem and cortex, now you're getting what's called a hemiplegic migraine, which are where you have patients that look like they're having a full stroke when they actually get an episode. And those patients respond really well to what we do. We really actually enjoy treating hemiplegic cases because the medications that you usually use for migraine are contraindicated in hemiplegic. So it's like, what the heck do you do? Yeah. But if you get this whole, bucket theory and you understand levels of activation, well, now it makes perfect sense to do these weird exercises, stimulate all these different parts of the brainstem and stabilize them. I've had patients that literally been stuck on the couch or stuck in bed for 7 months because they can't move. Wow. And we just changed their diet. Now they're up moving around. Then they come out here, you're able to treat them. Now they're back to normal. They haven't had an episode in years.
So if somebody has, they have is there, I guess the question I'd be curious is there a time where somebody just popping 4 ibuprofen is not going to put a dent in the pain? Is that the case?
Unfortunately, yeah. And that's where, again, by the time most people get to us, they've tried 15 different things and 40 different meds. So, that's not my specialty. So, typically, ibuprofen can help. Sometimes it doesn't. A lot of times triptans are really helpful. So that's, what most people are prescribed. But again, that's an abortive. It's helpful once the migraine has already manifested. It's not doing anything to actually keep it from manifesting to begin with, which is where the activation comes in. So it's one thing I try to get across is there is no such thing as a good or bad migraine treatment.
Okay.
Just for some people, they need the meds, or they need, acupuncture, they need nutrition. And some people, they don't. And that's where it's really frustrating, because every migraine patient has been told by 50 different people, oh, you just got to try this or do that, and that'll fix it.
Yeah.
It's maddening.
I mean, I'm even thinking of just, I don't know if they're just common headache or migraine myths of it's just hydration, or again, it's these pressure points, or it's just, you just need more rest or de-stress, or, so it sounds like it can be everything. It can be everything.
Yeah. Well, actually it's interesting. The last module that I taught is all basically about medication, surgeries, and psychology of migraine, because there's this huge stigma. There's this huge misunderstanding of it. There was a study out that said that of chronic migraine patients, the ones that are having like 15 or more a month, the spouses of those migraine patients, 75% didn't really believe that they were dealing with what they were dealing with. 75%. And so then you can imagine how that translates to stress and anxiety and guilt, and that makes things worse. And it's just this terrible cycle. And so when you can actually explain to somebody what's going on, give them control of it, that anxiety starts to regress. And that's where you see, again, a good progression of symptoms. Now, if they have clinically diagnosed anxiety or they're on medications, that's where, I won't even treat them at this point unless they're doing neurofeedback or seeing a psychologist or doing something to address that, because anxiety by itself is hyperexcitability of the neurons. And so if we can't globally handle that, it's really challenging to treat the migraine effect.
That's okay. So that just kind of blew my mind. So semi pun intended. So then if somebody if that's the way that they feel heard, or they, kind of going to that of, don't you hear me? Do you care for me in a couple setting? Or if somebody has OCD and it's that, that the obsession brings on that anxiety. I mean, so those things all could kind of go into that bucket, right?
Absolutely.
Okay. Wow. Okay. That's are you okay if I move on to brain fog, or okay. Cause I love I love that we kind of went down the migraine path. I have a lot of people that comes up in therapy a lot. And I can see the eye roll at times of a partner who feels like, here we go again, this excuse, which then the person feels not heard. And I love that. Okay. But I'm fascinated by the whole concept of brain fog. So is that just kind of a buzzword? Is that a diagnosis, or what is brain fog?
Well, it's funny. It's kind of like dizziness, where, I always ask people to explain it, because some people, when they say dizziness, they mean the room's spinning. Some people say they're spinning. Some people, they just get lightheaded. Brain fog's the same way. What do you mean? Like, are you having a tough time remembering things? Do you feel like you're just kind of in a haze?
Yeah.
Do you feel weird when you turn? Because all those things mean different things.
Okay.
Most of the time, it's just this cognitive difficulty. And we see it a lot with athletes and high performing professionals. So we'll see it with like attorneys and doctors and realtors and people that just have to be like quick on their feet all the time. And they'll say, what the heck? I've been doing this for 30 years. And now all of a sudden I can't remember, how to go through a contract, or I can't read a page, or I can't talk to a patient. And they feel terrible, right? But most of the time, say after a concussion or after head trauma, what happens, and this is, again, misconceptions with concussion, is they talk about like coup and counter coup and all this kind of stuff where the brain hits and where it rebounds. But where we're seeing most of the dysfunction is not necessarily where the cortex is hitting. It's the fact that no matter how your brain moves, you're tethering or putting pressure on that brainstem. So you see really, really common symptoms of vestibulo-ocular imbalances, vestibulospinal problems, so difficulty with eyes, balance, posture. And there's such basic mechanisms that help to tell your brain where your body is in space, that when it doesn't know exactly where you're at, all your brain resources are trying to figure out where you're at, right? Because if you don't know where you are in space, your brain doesn't care about anything else. And so now that brain fog you're having is really because you can't track a target, or you can't keep your eyes steady on something, or you don't know where your neck is, so you're locking it up. So now you have headaches and neck tightness and all these things. And so before I attack brain fog for being, a frontal mechanism or a temporal lobe issue, I like to start midline and try to fix the basic, eye mechanisms, balance mechanisms, head movement, all that kind of stuff, and then go to higher cognitive function like memory and dual tasking and those types of things. And there's tests that you can do to see if they're ready for that or if it's too much. But that's where we start is, can you track a target? Can you gaze stabilize? Can you walk without falling over when you're trying to say the alphabet or something like that? Yeah. And then after all that's good, then we move on to more higher order cognitive activities.
So it's really stepping it back and then kind of seeing where you go from there.
Exactly.
So when I have a client that will maybe say, I'm just, I'm slow moving in the morning. I can't think straight until I get my caffeine or that sort of thing. I mean, is there truth to that? Is that?
Yeah, well, sometimes that actually points to a different mechanism, which is more HPA axis dysfunction. That whole hypothalamic pituitary adrenal, or HPT, hypothalamic pituitary thyroid axis. And that can just be a tanked HPA axis. And so that's where on migraine patients, I always look at hormones because 90% of the time there's involvement. With concussion, there is literature to say that HPA axis becomes dysfunctional, but I don't see it as commonly. So I typically do the rehab first, and if there's still the fatigue and the brain fog, then I'll run a hormone panel on them. And I want to look at everything from their sex hormones to their stress hormones to their metabolites to see how everything's functioning. Because if that stuff's out of whack and you're exhausted, well, it's hard to concentrate if you just want to take a nap, right?
Okay.
And so that's one thing. If it's from a trauma, or if it's been ongoing forever, then you think about sleep studies, or you think about apneas or simple things like that. But again, it just kind of depends on when it came on and how long it's been occurring.
So I may or may not have Diet Mountain Dew in my Hydro Flask, but regardless of that,
I won't judge you. Yeah.
But I mean, are there some? I mean, I'm kind of the more I kind of hear about this, I guess we should probably take good care of our brains. I mean, do you personally feel like those things? The more you can kind of eliminate those kind of chemicals, the better.
Yeah, I mean, it comes down to what's called allostatic load. It's just how much stress you're putting on your body. And so most people think about emotional stress, which obviously is a huge one. Yeah. But you also have to remember chemical stress, physical stress, all these other things that contribute. And so like caffeine, right? Caffeine is one where I'm not that big of a stickler for most patients, but with migraine patients, I have people that do not like me. Because caffeine is a drug. We don't like to hear it, but it's a drug. It's the most widely consumed drug in the world. And if you take it as an abortive, like you get a migraine and you take some Excedrin that has caffeine in it, that can help, right? It can help the properties that it has, helps with cerebrospinal fluid flow. It helps with some changes in vasoconstriction, dilation. So in an acute phase, it can be helpful. But when you have it every day, it changes the way that your body produces all those different chemicals. Okay. And so it perpetuates these headaches. But when you get off of it, most people have withdrawal headaches. So now you get to the second, third, fourth day, and it sucks. And they say, all right, forget this, I'm going back on. Well, you were almost over the hump. And so once you get to that fifth or sixth day, your body stabilizes, you're in great shape. But most people don't make it. So they're like, I can't get off the caffeine. So I have a very, I have a no exception policy at this point because I've seen it screw up too many cases where if you're working with me, you're not doing caffeine for at least 2 months. And if you want to get back on it, I'm all for it. But most people, you don't have to convince them. When they feel great, then they have coffee, then they feel terrible. My job is done.
Hey, is that one of those things too, where do you know if somebody's not telling the truth about, if they're like, yeah, I haven't had it all week, but I mean, is there a way for you can you see that in the work you do?
There's not really a way to see it, but I'll be honest. Most people are very open about it and they don't hide it. It's almost like kind of like a comical pride sort of thing. Like, yeah, I had it a couple of times last week. Gotcha. And so I've never actually had an issue with people kind of secretly being on it. Right. You can also see it in their progression because we've done enough of these where I kind of know how I expect people to get better. And when they're not, it's like, man, we're missing something. What's going on? And caffeine is always the most obvious. So now it's kind of like I start from the beginning. I'm like, look, if we're going to do this, I get it. You'll love it. We're not doing it. And like a funny example, I had a lady like 4 years ago that was having migraines like 20 times a month. And she came in. I said, look, caffeine's something we'll have to deal with. And how much are you drinking? She goes, she's like, I'm having about 8 a day. I was like, 8 cups of coffee? Holy cow. She goes, no, 8 pots of coffee.
Pot? Oh,
and I go, what? And I go, no, that's not going to work. And so she's just like glaring at me, and she leaves. Never saw her again. But I still saw her fiance, and he comes in 2-3 months later, and he goes, I got to tell you, he goes, it took her about a month and a half, but she weaned off of it. And ever since she's been off of caffeine, she hasn't had one headache since then. Oh. And so I never saw her again. And I don't know how she did over the years, but I do know that she saw the direct correlation. It was awful for her, but she got off it. Now she's in good shape. So again,
that's how you wanted to say. I told you so off into the ether. Yeah. And her name was Mrs. Folgers, right? That was even the
exactly.
Exactly. Okay, so people, I don't know if I will keep this part in about the caffeine or not. No, I'm joking, right? That's
exactly.
That'd be good for people.
A bunch of people leave, yeah.
Exactly. Can I? So I a couple of things that I just kind of looking on your website as well, and which I'll have links. I want to, I mean, you've got so much good data on there. It's incredible. I've got somebody right now that has literally gone and had brain scans and come back and everything's fine. And do you run into that often where? Do you get people that are you're almost like the house of the brain, where people that don't know what to do and now you have to figure it out even if the brain scans look clean?
Yeah, no, it's so funny. I told my wife, after a couple of years into practice, it's like the longer I'm in practice, the more I identify with house. Not that I feel like I'm that good at it or anything, but you just kind of get frustrated because you hear the same thing over and over and over again. And you're like, I get it. Let me just get to work and see what I see. And luckily I haven't become that bitter yet, but what ends up happening is it's such a funny thing is I remember, I love the show. And one of the things that he says is, they ask, well, why are you different? He's like, well, I take people that have strange diseases and I figure out what's going on and I diagnose them. And she's like, isn't that what all doctors do? And I remember thinking yeah, isn't that how it works? And then you realize that's not how it works. And so what we're fortunate enough to be able to do is take people that have already gone through the brain scans and the blood work and ruled out all the things that are terrible, right? Okay. Now we can still do that, but nobody comes to me for that, right? They go to their medical neurologist, they go to their, primary care and they get the scans. Once they're clean, I can say, great. It's awesome news that you don't have a tumor, you don't have a stroke, you don't have this crazy infection, but you still have these symptoms. So now we can just focus on the function and say, look, whatever's going on is not what I call a hardware issue, right? So if your computer's messed up, you check the keyboard, the mouse, and the hard drive, and it's perfect. It's not a hardware issue, it's a software issue, right? Okay. So the stuff that we're going to do to test you is not going to be like, oh, this is an obvious tumor, right? This is going to be, this part of the brain is not firing or is not as healthy as the other parts of the brain. Doesn't mean there's an abscess, doesn't mean it's dead. It's just not as healthy as the other side. Easiest thing to think about is if you did, bicep curls every day on your right side and you never did it on your left side. Well, your left side might be totally fine, right? But it's not as healthy or strong as the right side. Okay? Yeah. And that's what happens with the brain. And so for migraine patients, for example, 99.7% of all migraine patients will have perfectly clean brain scans as long as they don't have any other neurological signs. So when they come to me and they're like, well, nothing can be wrong. Oh, my brain scans are fine. I'm like, yeah, they should be, right? That's normal. Yeah. And so that means we can get to work. And so now the cool thing is there's more advanced imaging these days, things like diffuser tensor imaging for concussion that can actually look for changes in the white matter. So that's where the brainstem gets tethered. You can see when that depolarization happens. They have SPECT scans, which looks for more functional changes, like Dr. Amen, psychiatrist, is really big into those. There's all these different things you can look for. But for me, it all comes down to the exam. And so we'll do things like posturography that we can actually map out and quantify their sway patterns and their balance and stability. There's things like the video nystagography, which is where you can use video cameras to track eye movements and all these different things. You can quantify all that stuff, but realistically, you can see it all bedside. Right? It's not like it jumps out at you all the time. Simply, but when you do this over and over and over and over and over again, you know what normal is supposed to look like, and you can see when there's an aberrancy in, say, a pursuit mechanism or in a gaze holding or in a saccadic activity. And then you start to build a case to say, they kind of had an issue falling to the left when they were doing a Romberg's, or they had an aberrant VOR when they were going this way, or their pursuits are kind of crappy to the right. And so now you're starting to think, there's something going on in that left cerebellum. So let's do therapies that could make that better. You try something. If those tests get better, you're doing something good. If they get worse, you're not doing something good. So it's kind of a test and measure type exam. And then we can say, look, here's the therapies we think that are going to improve that brain function. And then that's how we get to work.
Well, I like that. So, because in therapy, I'll run into somebody tries something, they do a little mindfulness, they still turn back to an addiction, and they're like, there you go, it didn't work. And it's like, no, we're going to keep trying. We're going to keep going. What's next? So it sounds like I really like that. I mean, you're just saying, all right, keep giving me data. There's a lot of things we can do with that. I like that. I don't want to get to the end of this before. I mean, you've got a method named after you, the Harcourt Method, and is that around traumatic brain injury? Or I haven't even talked to you about concussions. I'm fascinated by them.
Well, it's funny. It was kind of a tongue in cheek, because I was just doing things differently, and I was like, I don't know, because I teach other doctors, and when I'm trying to explain it, they're like, where is this from? I'm like, I kind of make it up. Just call it the Harcourt Method. And it was.
Okay, I love that, by the way, because I was like, okay, you're a regular human being, right? Because I was like, you're like, I think we'll call it the Harcourt Method.
It was just kind of fun. And essentially what I did is there was, when we were going through the TBI program, it's a really advanced program on eye movements and different assessments and treatments and all this kind of thing. And so one of the biggest challenges I was seeing to doctors getting into this type of treatment was they're like, there's a million things that we can do. What the heck do we do? And so we'll look at, pursuits or saccades or VORs or optokinetics or all this stuff. But at the end of the day, you still have to do something with that patient. And so what I started doing is just having them doing some very simple fixation on different targets. And I would have them move in different directions, inflection, extension. We would do left and right yaw as far as, anterior, posterior movement. And you can correlate that to eye muscle dysfunction. You can correlate that to canal dysfunction. You can correlate that to cerebellar dysfunction if you're more advanced and you kind of understand those things. But if you don't, I said, look, just figure out where they're not moving great and give them gaze stability in those directions. It's just a starting point, right? And it's, for those that have taken more advanced, traumatic brain injury modules and understand, they're like, that's pretty simple. I said, I know, that's the point, is you need something to sink your teeth into. So then when it's not working properly, now you understand why, pursuit or saccade or VOR or Romberg's or whatever is important for diagnosis. But if you know nothing else, well, you know where there's an aberrancy in the way that they move their head or they gaze fixate, then you can give therapies that help to recalibrate those systems. So that's kind of my simple method.
No, I love it. So it's like, my son plays basketball. If he can't dribble with his left hand, everybody else is like, well, let's work on his 3-point shot. Let's do whatever. You're like, how about he dribbles with his left hand for a little while?
Why not? Yeah. And that's the thing is
the Harcourt Method. I love it.
And it can.
No, I love that.
Now for us, we use it more as a confirmation. So after I've done my whole exam, I'm like, all right, I expect this to be messed up in this direction. And we just confirm it. But for people that haven't been doing this for a long time or that are just trying to learn, it's like, yes, there are all these things you can consider, but here's something that you can just try, give a test, give a therapy, have them come back, retest it and see if it made a change, right? It's just a real simple way to get started.
And in those kind of situations, we're talking kind of like if I have somebody that does mindfulness a couple of days and says, it didn't really work. People have to do these exercises, is it hours or days or weeks? To really carve in those new neuro pathways, or is that what we're trying to do?
Exactly. We know in research that actually to create, neuroplastic changes, it takes about 6 weeks of consistent treatment. And so normally we're doing a lot of kind of changing and then doing new therapies and altering them and increasing them. But once we get to a point where they're pretty stable, then I have them keep up with exercises on their own for about 6 weeks at least. Now, there's some cases where there's genetic abnormalities like movement disorders, for example, like dystonias and tics and myoclonus. A lot of times you'll find that that's just genetically different. And if they keep up with some therapies here and there, they do really well. But if they kind of stop or they go months or years without doing it, then it starts to pick back up. Whereas like with concussion, a lot of times you fix it, they get better, and then they're fine, right?
Okay.
So it depends on the case and how they respond to the therapies.
Do you weigh in on, and you don't have to at all, but in the world of traumatic brain injury, do you weigh in a lot on concussions and sports, and do you get asked a lot of those type of questions? Yeah,
we've done outside evaluations for former NFL players, and we work with some professional fighters like in the MMA, UFC actually. And so, we'll get opinions asked on that because the way that I diagnose and assess for concussion is different than like a neuropsychologist or a neurologist. And so we're looking at, vestibulo-ocular responses, vestibulo-spinal responses, and things that you can't really fake. So if you do a 4 or 8 hour neuropsych exam, they're looking at all sorts of great stuff, but it's more cognitive. Whereas we're looking at stuff that's more reflexive. And so if you combine those two, like a neuropsych exam with what we do, you got a pretty good idea of how disabled or how severe it is. And so we, and I actually go out and I teach this stuff to coaches and athletes and other people, so that there's really simple ways that you can assess for this stuff. Sideline, where it's free, you don't need baselines. And so, my goal is more education than anything else, because the longer you go without treatment after concussion, the harder it is to fix.
Gotcha. Okay. So you try to stay away from, if somebody says, should my kid play football or should my kid fight? Is that kind of, hey, that's up to you? I mean, but. Well,
the big thing with the NFL was basically they were trying to say that it wasn't causing damage, right? And now it's kind of out there that it is. Kind of like, if your kid wants to be a boxer, right? We've all seen boxers. Nobody's thinking that it's like a healthy sport or anything like that. But if they want to box, they're taking on that risk, and they know that there's possibility for brain damage. Same thing with fighting, same thing with football. Now, the NFL is doing things to try to reduce that risk, right? There's new helmet technology, there's new diagnosis. They're working on it, right? But the reality is, you're still the biggest, strongest guys you've ever seen running into each other full speed. It increases your chance. Doesn't mean you definitely will. It just definitely increases your chance. So understanding that risk going in, if you want to play, that's fine. I've said if my kid wants to play football, he's more than happy. I'm more than happy to have him be the kicker or the punter.
Right.
But outside of that, I think we're going to hold off from football.
And I've been able to work with a few professional athletes, football players, fighters, and it is. I mean, they're very. I feel like, and of course, call confidentiality. I feel like they're aware, of the risks and that sort of thing. At least at the time when they're playing, and so people just telling them you shouldn't or whatever isn't necessarily very productive. I mean,
doesn't help. They're going to do it, and that's the thing is if we're saying yes, you should play this sport and there's no risk, that's not okay. If you're saying, hey, look, there is some risk. If you want to play, go for it. I'm perfectly happy. And so, like our fighter patients, I always tell them, I'm like, I can never encourage you to do these things, but knowing that you're going to do it anyway, in between fights, we'll have them come back and just make sure we can tune things up and get them as stable as possible. So A, their brain function is as good as it can be, but B, now when they go in for their next fight, they're less likely to get, hit as many times. So then they're more likely to be stable. So that's part of the strategy behind it.
No, I love it. Can I ask you, before we go, do you have just kind of simple brain or eye exercises that if somebody's sitting there, if they're riding to work, if they're, commuting somewhere on a plane, whatever, that you recommend doing? I mean, because I think this is also based on the, doing Sudoku or word searches. I mean, are those really, healthy brain exercises, or do you have kind of more evidence-based ones?
Well, and for what specifically? Just
that's a good question. And nothing, just kind of like, hey, if I'm sitting around, I could either be playing Candy Crush or I could be doing, because I'm a big fan of now starting to turn to, all right, let's do some breathing and we'll count, nose out through the mouth. Or are there any things that maybe would be good with your eyes or that sort of thing?
Yeah, so there's a lot of things. I mean, I encourage any type of rotational or translational activity. So, traditional gaze stability exercises, rotational stuff is all good. Obviously, I don't encourage them while you're driving or in the car. So a good, way to go about it is there was a great study out of Stanford a couple of years ago looking at neurocognitive function over time. So they took patients that were like 75 years old all the way up to 95 or until they passed away. And they were looking at every factor from social to environmental to everything they could. And they said, what reduces your chances of having cognitive decline over time? And so things like crossword puzzles and Sudoku, they actually reduce cognitive decline by like 45, 48%.
Okay.
Pretty incredible.
Yeah.
Good diets helped a little bit. But the number one thing that they saw across the board, this is like 25,000 participants, the number one thing that reduced cognitive decline by 76%, which blew everything else out of the water, guess what it was?
I want to say, please don't be sleep. How about exercise?
That's what I would have thought. That in that study, they didn't show a big improvement there. There's other studies that do show a reduction in with exercise, but it was dancing. It was people that dance on a regular.
Dr. Harcourt, I was going to say, I only feel alive when I dance because I don't know how to dance. Okay, really? Dancing?
because think about it. It's one of the few things that causes you to do what's called a dual task, which is where you're doing motor activity and you're having to think about it. So actually the fact that you're not good at dancing is awesome for your brain, right? Because
thank you.
Because you're trying to get better at it. And so I tell people if they're, starting dancing and then they just master the foxtrot, they don't even have to think about it. Well, learn something else, because now you're not dual tasking yourself. But the people that danced on somewhat of a regular basis, and they start at 75. So it doesn't mean you have to do it your entire life.
Okay.
The people that danced on a regular basis, they did awesome.
That's awesome. You gave me my clickbait title too. I mean, gotta wait till minute 40, to find out the key to longevity, right?
That's right.
I love it. So Dr. Harcourt, this was awesome. I mean, I would love to have you back on too. I mean, I feel like
thanks so much.
Maybe next time we can tackle some of the I don't know, some nice myths of the brain or that sort of thing.
Love to.
Where can people find you?
Yeah, so the most active we are is on Instagram.
Okay.
We're at Migraine Doctors. You can also find us on our website, ixneuro.com. That has all the information about both our Santa Barbara and our Beverly Hills office. And then the book that I'll be having come out soon is going to be titled Mastering Migraine. Okay. And should be out soon. We're working on formatting right now, but that's kind of the last step. And if you have any questions, obviously you can call in or contact us. But like I said, we're happy to reach out. There's so much misinformation. All we're trying to do is get it out there. So, we encourage questions. We really
I absolutely love this. I mean, I really enjoyed this. I'm kind of being very authentic as my therapist self. Very easy to talk to. Not like I was worried like I was going to run into some super brainiac that was going to make me feel bad.
No such luck. Yeah.
I mean, the brainiac is there, but also very well versed. The last thing I have to tell you, when I was a child, I don't know how old you are. Do you say that on the air?
I'm 33.
Okay, all right. So I'm a much older man, and I used to have the Guinness Book of World Records maybe in the bathroom. And so I remember always being fascinated by the world's tallest man, because I am the opposite of the world's tallest man. Sure. And they talked about that he had, had some pituitary tumor. And then anytime I would see some giant, you would read about this pituitary tumor. And when I was young, I used to fantasize about maybe taking a fall on the playground and just smacking that pituitary gland and then just growing. Yeah. Have you ever seen this? Is this something you've run into?
I hate to bust your dreams, but it's not really a thing. Now, if somehow you got some swelling right around there, it's possible, right? Maybe. But yeah, that's like Tony Robbins. That's what he has, same type of deal. Okay. So yeah, it's what Andre the Giant had. It's a pituitary tumor. You just get a continual and increased release of this HGH, and you get big. That's kind of the deal. But usually that doesn't correlate so well to health, which is why I think people are very health conscious. But sorry, I don't think that's
okay. There. And I think at 49, my dreams of the NBA, I think so. Dr. Harcourt, thank you so much for taking the time, and I can't wait to talk to you again. All right, I'm gonna hit stop, but hang on one second.